Thanks everyone. Today, I'm very happy and very excited to come here and learn with everyone on this APSC CME webinar series, focusing on overcoming the complexities in left main PCI. This event is organized by the APSC timestamp. Today is Friday, 6th November 2020, 3 p.m. Singapore time. This CME webinar series with a live case focus is conducted out of Sengkang General Hospital. And we're very proud to bring you this event through APSC. This event is also endorsed by the Singapore Cardiac Society PCI chapter, co-endorsed by the Asian Pacific Society of Interventional Cardiology, supported by Sengkang General Hospital in proud collaboration with Biosensor International. I'm your chair today. My name is Jack, interventional cardiologist coming out of Singapore, the president of the Asian Pacific Society of Cardiology. My first speaker is Professor Tan Wee Cheem, Director and Senior Consultant, Department of Cardiology at the National University Heart Center. And he's going to give us the opening lecture on tips and tricks in managing left main disease. My second speaker is Dr. Fahim from Tan Tock Seng Hospital, Department of Cardiology. He's going to speak to us on left main stenting, when, how, and who. My next speaker comes from Switzerland, Dr. Florim Cuculi, and he's going to speak to us on highly calcified left main stenosis. Pressure is the answer. My live operators today will be my boss, Aaron, from National Heart Center Singapore, operating with Dr. Idu, also from the Heart Center. Dr. Chieh is going to narrate and guide us through the intravascular imaging component of the case. I'm very happy and proud to have my friends as panelists. From Malaysia, we have Dr. Ramesh Singh from the University Malaya Specialist Center, Malaysia, and Professor Josowin, cardiologist at Mandalay General Hospital, Myanmar. We also have our zone APSC Vice President, Assistant Professor Joshua Low from the National University Heart Center, as well as Professor Quang from the Hanoi Medical University, Vietnam. The session coordinator for today is Dr. Ke Yen San, who is coordinating everything on the back end. And we also have handpicked 3 of our registered fellows in this session to dial in live, and they will provide the live feedback that we need from the fellows, and they will hopefully ask all the appropriate questions on behalf of everyone as well. So Dr. Alfafi Katirasri from Indonesia, Dr. Eric John from Philippines, Dr. Gufram Adnan from Pakistan. This APSC webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. The content is currently live streamed via Wonder, APSC Facebook, as well as YouTube page. For Singapore registered physicians, CME point will be awarded for attendees who are connected throughout the whole duration of the webinar. You'll receive your certificate of attendance upon completing a survey sent via email after the webinar. For the participants dialing in, feel free to click on the Q&A. I'll get my faculty to help me in replying to you on the chat box or in the live format. We have one more upcoming webinar before the end of the year. 13 November, we're discussing cardiovascular and renal risk factor management in diabetes, evolving concepts and treatment strategies. And another advert, end of the year, we have a free to register event in conjunction and collaboratively organized and planned with ESC, the ESC Asia 2020, 4th to 5th of December. So the learning objective today, our session focus as usual is on fellows and in-training physicians who are interested in complex interventions to learn the basics. So today we want to narrate the ideal patient that should and can have a successful left main PCI. We want to talk through and simplify techniques and improve understanding when performing a left main PCI. And we want to understand the role of ultra-high pressure balloon in highly calcified lesions. So let's get started. And without further ado, I'm going to stop share and invite Professor Tan to give his first lecture on tips and tricks in left main PCI. Prof. Cheem, please.
Can you see the slides, Jack?
Yep, clearly.
Thank you very much for the opportunity to speak at the APSC webinar. So my task is to talk on tips and tricks in managing left main disease. But I think before we go into that, let's know about the unique considerations in PCI of left main artery. Frequently, it has got a left circumflex side branch, which is large in terms of reference diameter and angulated, which make it difficult to access with guide wires. The bifurcation angle of the left main stems affects directly your implantation technique. The occlusion of the side branch in this situation usually results in considerable ischemia. And left main is the only bifurcation where the proximal main branch originates directly from the aorta. And this increases complexity because of the interactions with the guiding catheter and the potential for the guide wires to go behind the left main stent struts. Other considerations include if you do a stenting, that could be longitudinal compression during left main stenting, which when untreated is associated with an adverse outcome. The proximal reference diameter may go up as much as 6 millimeters, which is close to the dilatation limits of many coronary stents. So careful reference to the manufacturer's guidelines is recommended. Left main trifurcation is encountered in about 10% of left main cases and requires specific treatment strategies. So in terms of bifurcations of PCI of the left main artery, there are basically 3 strategies. 1 is to keep it open, 2 is provisional stenting, and 3 is the 2-stent strategy. The keep it open strategy is really reserved for side branch of the left circumflex, which has osteo or diffuse disease, when it's not suitable, either too small for stenting or clinically not relevant. For provisional stenting, it will be for situations where you have insignificant stenosis at the osteosuck with Bundiner classification of 110 or 100, small circumflex, diminutive circumflex, wide angle between left anterior descending and left circumflex, and no concomitant disease or only focal disease in left circumflex. The good thing about provisional stenting is that it's a simple and fast procedure. It's got excellent short-term and long-term results, and it's reserved all other options in case of failure. So you're still available to do a 2-stent strategy if the need arises, and more than 60% of left main bifurcations can be treated using the provisional technique. The side branch stenting only needs to come in during a provisional approach when there is significant side branch flow impairment, when there is a major side branch dissection, or when the side branch is diseased and large enough to lead to a significant residual ischemia after your main vessel stenting, or where future success towards the side branch becomes your concern during the course of the procedure. The third strategy for left main bifurcation is 2-stent strategy. And we all know that the strategy is really based on the morphology, which is the angle. So is it more than 70 degrees or is it less than 70 degrees? So if it's more than 70 degrees, tap technique, less than 70 degree, keloid or crush technique. We talk about T-stenting being a choice of 2-stent strategy in angle that is huge, but T-stent strategy has a problem in terms of coverage of the side branch ostium. So that's why we don't do T-stenting so much. We go for tap technique if you want to use a T-stenting approach. So basically, tap technique is when you put a stent in the main vessel, take a balloon, go into the side branch, then take the stent, put it position the side branch covering the ostium, inflate the side branch stent, and then pull back a little bit, do a simultaneous kissing, and then you are done with a tap technique. When you have a angle that is less than 70 degrees, we talk about keloid stenting favored by the Europeans, first described by Chevalier in AJC 1998. This technique allows for adequate osteo coverage, both in the primary 2-stent strategy and also perhaps a provisional side branch stenting technique as well. The proximal vessel to bifurcation have double layer sleeve of stent, and that is the downside of it. The proximal end of both main vessel and side branch stents will need to be sized up to the proximal vessel, and that is an important consideration. Both the main vessel and the side branch need to be fairly close in terms of its diameter, and you need to ensure a stent design that will have a cell space that can be expanded to the size and diameter of the side branch. So if the advantage is good for all kinds of bifurcation and provides a near perfect coverage of the side branch. Besides, in terms of disadvantages, besides the high concentration of metal, rerouting of the side branches sometimes can be difficult and time consuming. And there is also a need for both stands to accommodate the potential diameter mismatch between the side branch and the more proximal vessel. One of the tips in terms of wiring of the side branch in the keloid stand technique is that you want to go to a distal cell space, because by doing so, you will allow the projection of stents into the ostium of the side branch opposite the carina, and this will allow you to have a much nicer coverage of the ostium of the side branch compared if you go into a proximal branch where you're going to not have very good coverage of the side branch. When you talk about DK crush technique, it is a 7-step procedure, which I'm not going to go into details, but suffice to say, these are the 7 steps in the DK crush stenting technique, best supported by intravascular imaging. The advantage of crush stenting technique is that it's an effective technique for complex left main bifurcation. Definitely preferred to classic crush because side branch access is often assured in the DK crush approach. The disadvantage of a DK crush technique is that it cannot be performed as a provisional strategy, and there's a triple stand layer in the lateral wall of the proximal main vessel. Multiple steps is involved here, and few operators have experience with this technique. So what are the other tips and tricks of left main bifurcation? We talk about proximal optimization technique. Why do we have to do that? Is to correct for any underexpansion in the proximal main vessel, is to restore the proximal main vessel circularity. You want to facilitate the side branch rewiring, because by doing a port, you can actually open up the cell space to allow your side wire to go, your branch, your wire, guide wire to go into the side branch, and you provide a scaffolding of the side branch. And so the common technique now is to position the distal balloon marker just at the proximal end of the carina here to allow for good port. We also need to do kissing balloon in 2-stand strategy in left main PCI, very important, because you want to modify the geometry of the implanted stand. You want to improve the expansion of the ability in the proximal main branch. You want to improve the results in the side branch as well. You probably do best with using a 2 non-compliant balloon, and you want to size according to the distal reference of the side branches, and allowing only for a very short proximal overlap in the kissing balloon inflation. But if you don't like kissing balloon inflation, the alternative is to do what we call port, side branch dilatation and port, which is an alternative to it. And it will give you the same sort of a final results, maintain circular geometry, reduces side branch obstruction, and so forth. And finally, I want to talk about 2 aspects. One is the role of intravascular imaging. Certainly, you will be encouraged to use some form of imaging, either IVUS or OCT, because it can provide you with essential information for assessment and treatment. It provides insight into the plug configuration and perhaps even diminish the unnecessary use of 2-stand strategy. It may improve outcomes and allow selection of an appropriate stenting strategy, and allow for vessel sizing. If you would need to quote a trial, this will be a trial in the left main stenting by Park, suggesting that the use of IVUS has got an impact on mortality as you follow a patient up to 3 years. And what about the role of FFR assessment, physiologic assessment? No question that bifurcation and left main stenosis can be accurately evaluated with FFR when there are no significant stenosis located downstream, as evidence in some of these 4 trials that have been carried out. And FFR-guided revascularization strategy can be safely applied with bifurcation and left main disease. IFR has not been evaluated in this setting yet. So in conclusion, I think the goal of PCI and left main bifurcation lesion is to attain an optimal result in main vessel and maintain physiologic patency of the side branch. While provisional side branch stenting should be the default technique for low-risk bifurcation, a 2-stent technique may be preferable for high-risk or complex bifurcation, and this is increasingly so based on the recent publication of DK crush and definition trials. The DK crush technique seems to be the most favorable, but TAP and keloid are also excellent options. And you want to employ imaging, physiological modalities to save time and optimize outcomes. Thank you very much.
Thanks, Cheem. Again, fantastic, concise lecture, keeping to time. So congratulate you again on a fantastic starting tips and tricks to left main PCI. Can I start off by welcoming our dialed-in fellows, our 3 Darwin Fellows from Pakistan, Philippines, and Indonesia. Maybe we'll start with you first. Do you have any questions for Prof. Tan on his lecture? Don't be shy.
Thanks, Doctor. I have a question.
Yes, please go ahead.
I'm Eric from the Philippines. Okay. So Professor Huay mentioned that the one-stent provisional technique is preferred for simple left main lesions, and then the two-stent technique or the is preferred for high-risk lesions. So as beginning interventional fellow, so what are these high-risk features that we need to take note of during our procedures? For example, is presence of a thrombus a high-risk feature, or multiple bifurcations, or what will be the length of the main branch disease, or the bifurcation angles? So can you enlighten us with this?
Yeah, so Eric, actually, I will defer you to the definition 2 trial, which was just presented, I think, in ESC this year. So in the definition 2 trial, it helps you to identify who are the complex bifurcation stenosis. And essentially for left main, we will be looking at a side branch of more than 50% narrowing and the length of 10 millimeter or more. Or in the non-left main, you will be looking at 70% stenosis or 10 millimeter and plus 10 millimeter in length. So this is considered a major criteria. Then you need another 2 minor criteria out of the 6 that are listed. The length of the, whether they are tandem lesions, whether they are thrombus, whether they are calcification, angulation, and so forth. So you need a 1 major plus 2 minor to qualify for a complex PCI. And now complex PCI cannot be treated with a simple strategy. Simple lesions should not be treated with a complex stand strategy. So now you want to reserve complex PCI for complex lesions only. And so definition 2 will be a good start.
Excellent question.
Thank you, Doctor.
Any other questions from the fellows?
It's Gufran from Pakistan. I want to ask the question. So my question is, if you consider the provisional strategy, in that you recommend to go every time for kissing balloon inflation, or you need to only go for standing of the means?
So excellent question. Do you always kiss? Do you just pot, Hui?
So this is a question that has been asked many times over. If you look at the earlier trials of Nordic 1, 2, 3, 4, particularly 3 and 4, looking at the strategy of routine kissing over no routine kissing after stenting, you find that there was no benefit in terms of kissing balloon inflations. But there are proponents for kissing balloon inflation, chiefly because you can push the, you allow for easier access in future, you avoid some kind of a hemodynamic perturbation across the side branch. You also can prevent thrombus formations that have been spotted in some of this imaging study of a side branch with stent struts across. So my personal take is that if the this is a large vessel and that the flow is good and that there's no concern with future intervention, I feel that a routine kissing balloon inflation is really not necessary here. But if there's any concern of future access and so forth, perhaps you might want to do that. But as a rule of thumb, I think routine kissing balloon inflation is not indicated, I think, most times.
Again, excellent answer and great question. Any other question from our last fellow? If you don't have, it's fine too. If no, can I get a sense from the panel or Hui Chim again? What was missing and what was one of my objectives is picking the correct left main patient. We know that a lot of left main patients are associated with high syntax, high tertile, multivessel disease. What consideration goes into your decision tree? Any surgical reject is suitable? Or is there anyone that you say that, how do you decide? If you can get a great result, is that good enough for you, Hui Chin, to decide on this?
So it depends on how strongly strongly you believe in terms of Excel trial. So I do believe that there's a certain group of patients that perhaps can have a clinical equipoise with bypass surgery, and Excel trial and the earlier very much Syntax trial does give me the confidence to do PCI in relatively less complex lesions. But that's not to say that complex PCI of the left main cannot be done. But as you said, I think it's always going to be a hard team approach in terms of assessing the complexity and benefit in which these patients will benefit from whichever revascularization strategy. My take here is that oftentimes it's going to be morphology determined, and if it's a straightforward left main lesion crossover type, I think the long-term outcomes compared to bypass surgery is going to be good. But when you have left main plus triple vascular disease on top of multiple comorbidities such as poor LV function and diabetes and renal impairment, maybe you want to consider surgical revascularization. So it's going to be a hard team approach in terms of a selection of patients for left main intervention.
Thanks, Cheem. Any comments, teaching points from our panelists and other speakers?
I think I'd echo a lot what Cheem has said. I mean, I think the key differentiating feature for me is always the extent of the remaining disease. The left main is relatively straightforward. It's the disease complexity elsewhere. If you have multiple bifurcation lesions, CIRC-OM, LED diagonal, multiple CTOs, those are the kind of patients where, when you're putting in miles and miles of stent, the long-term outcome with PCI is not going to be that good. And I think surgical revasc is better. And the data will support it. Left main with complex disease, they do better with surgery. But left main with intermediate complexity of the remaining disease, they do fairly okay with PCI. And, I'll hopefully talk about some of that data in my talk.
So a proponent of residual syntax. Ramesh, you recommend?
Yeah, I mean, for me, one of the thoughts I put in is how calcified the left main is as well. Of course, that's not a hindrance as long as you make sure you prepare your lesion beforehand. You probably have to end up using scoring balloons, even rotablation as well. Because if you're going to do even if it's provisional and your left main is calcified, you're not going to get good long-term outcomes. That's one. The other thing is I just wanted to ask Prof. Tan, what about in provisional stenting, how important or how significant is it to, if you see that your left main, the ostium of the circumflex is diseased, so what about considering FFR to guide your next step, whether you put a second stent or not? Do you think that's useful?
I think if you believe in the Nordic 4, it tells you that routine kissing balloon inflation is probably not necessary unless patient symptomatic and high-grade stenosis and ECG changes and so forth. But if you look at some kind of a coronal sheath with diminution in terms of the diameter of the circumflex, and if you are really worried, you could always do a functional physiologic assessment, but that is not something that I do. Once I set up for a physiologic assessment, a provisional stent approach, I really need strong indications to intervene in the side branch, because I would have generally considered a provisional approach for a less than complicated left main bifurcation. So for me to now convert it into a two-stent strategy, it has to have something quite significant. And in terms of ischemia.
Thanks,
The patient has no chest pain. I mean, the flow is symmetry, there's no ECG changes. Most time, I think even if you do an FFR, it's going to be normal actually. Yeah. Thank you.
I agree.
Thanks. I like the discussion. I think you can hear from the train of thoughts from the fellows that I think most people just want to keep the technique simple and safe with great long-term outcome. I think professional is something we don't emphasize enough. Maybe if there's a chance, we will rehash some of the tips and tricks to a good professional provisional technique as well. Is there any last pressing comment from the faculty before I move to the live case?
So while it is good to go with provisional approach, but I think fellows should also learn at least one or two two-stent strategy, so that in treating a complex lesion and build out or whatever, that you can always fall back on one or two of these two-stent strategy and techniques. Yeah.
Thanks, Cheem. Point well taken. So the data does show that if it's a true complex Medina 111 bifurcation, they do benefit from an upfront two-stent strategy rather than just pure complex. So Obi-Wan, can we switch back to the live case? So I'm going to stop share. OB-Van, can you share Cam 1 in the Cath Lab, please? So, Aaron, I don't know whether you're muted or can we hear you? OB-Van, can you unmute the operators?
Are we live?
Yeah, so Aaron, you're live now. We can hear you and see you.
Okay, wait, let me just secure the wire.
Yeah, so you need some time, right? Am I good if I just share the slides for the case and then?
Edu, you want to present the case? Okay.
Yes. So we have Aaron with Edu and Jion helping out with the live case. We're going to use this live case just as a talking point and just look at the complexity in the left main bifurcation. So OB-Van, can you stop share for the time being?
Okay. Can we present the case?
Yes. So if you can see the case history, Edu or Aaron.
Okay, so our patient is a 70-year-old male, risk factors of smoking over 25 years and dyslipidemia, history of essential thrombocytosis, also a history of previous stroke in 2015, and CT angio then showed diffuse internal carotid artery stenosis. Next slide. So he actually presented with an NSTEMI in June. At that time, he declined intervention, so he was medically treated, and he came in for a recurrent angina in September. Coronary angiography then showed a dual vessel disease with distal left main stenosis as well as proximal LAD and OM disease. CT angio done showed left internal carotid artery occlusion and bilateral vertebral artery stenosis. He was actually referred to the surgeons, and then a heart team discussion was done, and he was deemed very high risk for CABG because of stroke, and the decision is for PCI. Next slide. These are his baseline labs and ECG. So HB normal, creatinine normal, ECG normal, LDL suboptimal, no diabetic. Next slide. This is his chest X-ray. So his syntax score is 37, which puts him at a higher group. Euro score is 1.25. Next slide. This is his angiogram on the left coronary system. So there's the LAD and diagonal disease as well as a SUG. The SUG is small, but there's an OM disease too. Next slide. It's the aerial cranial aleocaudal view. Okay, next slide. AP cranial view. So there are surgical targets, but unfortunately not suitable for CABG. Next. This is the coronary for the right. Some osteo-RPDA disease. Okay, next. So this is a summary. And Dr. Wong, you want to give the strategy for today?
So it's quite a complex.
Aaron, can I hold your thoughts first?
Yeah, sure.
I just get a quick discussion before you tell us what you plan to do. Maybe I get the opinion from Josh. Josh, we are talking about deciding the ideal candidate for left main PCI for fellows. Do you think this is appropriate flow and candidate for left main PCI?
Any balloon.
Yeah, wow, this is quite a complex case with high syntax score, and you know, from the presentation, I already see quite a few bifurcations that I may have to reconstruct. There's quite a significant diagonal there, almost like a dual LAD. So I do think that that area needs to be treated adequately, perhaps even a 2-stent strategy. And of course, you can see the disease extends all the way to the osteo-LAD, and we have to cross over to the distal left main. What I'm worried about is that, if I choose a provisional approach for the left main, it may actually affect my access to the circ later on, which is also quite diseased. So I think it's a really complex case, but since the patient has a very, very high risk of stroke based on his ICA stenosis, and I think PCI is a reasonable strategy. I think at the moment we do have techniques and contemporary devices which can allow such complex cases to be performed percutaneously. So I think in this case, I'll just go ahead with PCI.
Okay, Obi-Wan, can you go back to Aaron for him to show us what his strategy is? And hold that thought. I'm going to ask our colleagues from Vietnam and Myanmar, do you think you'll just go, do you need any intravascular imaging actually for this type of case? So Aaron, maybe you'd like to tell us and talk through us with your strategy today.
Okay, so as you can see, the left main is diseased on the angiogram during the presentation. So there's a worry that the guide may jam into the left main and causes pressure damping. One choice is to use a side hole, but for left main stenting, especially osteo stenting, I don't like the side hole because it's very difficult to position the stent, because when you test it, the dye doesn't fill up the left main very well. So I elect to use a non-side hole. And then as you can see this angiogram, I sort of purposely not engaging the left main, so you can see the lesion. Diagonal, quite long lesion, LAD long lesion as well. Proximal LAD very tight. And there's a circ, also the ostium very tight as well. Actually, looking at it, after reviewing the angiogram, the circ looks like quite a big, moderate sized territory. Yeah. So we just wired it without engaging the guider. So it went down to the LED. And then we wired the diagonal as well. This one to measure the length of the lesion. And then we put the third wire. I use a 7 French guide from femoral because we think that this is very complex and we need to use quite a few wires to protect the branches. So that's why I use a 7 French guide femoral. Yeah. So the question now is what technique that we use for the diagonal and the LED. So looking at the angiogram, I just play back the first one. I initially intend to do a culotte, but the problem is culotte is just that once we stent the side branch, there's a possibility that we may lose the main branch, because if there is very tight lesion at the main branch, we may not be able to wire it. Yeah. So but we would, since the angle is very shallow, so I think it's better to use a culotte rather than a crush, because for crush, when you crush the stent may lift up from the side branch, and then the ostium may not be covered. So my intention plan is to do that. So we wire it, we pre-dilate it sort of with two balloons.
Aaron, can I take a pause here? Can I check with you, your upfront strategy is you're thinking of 2 stent, or you're thinking of provisional, or what are your thoughts?
Sorry, the LED or?
LED left main, the bifurcation. Oh, yeah. Why are you thinking?
So we just sort of changed our mind at the last minute. So let me just show you what we did actually. So we thought that the circ very tight. So if you leave a wire there, it may get ischemia. So we just balloon it, and then it looks quite a big size. So I was we discussed, and then we thought we're going to make it a bit more complex. So we actually decide to do a crush for the circ and the left main, because it's pretty big vessel. So we balloon it, and then
so can I just say circ left main is a crush as in a classical crush or DK crush that you're thinking about?
Yeah. So that we plan to do a DK crush. So this is the stent placement in the spider view. Can you change your spider view, please, Obi-Wan?
Lateral
spider view. Yeah. So placement of the stent, just protruding into the left main, and then deploy, and then pull back high pressure, and then we crush the stent, and then we pot it with a 3.5 NC balloon. So that was the crush, and then we wire it, and then we use a 1.0, 1.5, and then 2.25. Eventually dilate the ostium of the 2.25 here. We didn't record it. It was 2.25. Yeah. But before we want to do a kiss, unfortunately, there's a wire wrap. So the 3.0 balloon in the LED, we can't get it in. So we just do what we call double rewiring rather than double kissing. Some people think that the second kiss may not be necessary because we're going to push the stent strap back to the wall again anyway with the left main stenting. Yeah. So anyway, so since we can't get the balloon across, so we just do a double rewiring sort of crush technique. So hopefully when we rewire later, it will be easier because we open out the stent straps a little bit. Yeah. So that is where we are now. So we are going to planning to do the culotte for the left main LED.
Can I just take a pause here, Aaron? So you're talking about culotte for the diagonal LED and DK crush for left main circ. Is that correct?
Yes, correct. Yeah.
Can I now ask my fellows in the gallery, what would be a fellow's approach to this case? Maybe I ask my Pakistani fellows, follow my Philippines fellows.
Okay. Yeah. So can I have the?
Yes. So I would like to go definitely with the femoral approach with a 7-French sheath because this is a complex case, and for this case I would like imaging to guide me so that I have an idea how to approach this case. So I will go for DK crush for the left main stenting, although it's proved to be the better strategy, and for diagonal and LED I will prefer the culotte technique.
Okay, so you agree with Aaron, then we'll show you the intravascular imaging. Eric?
Doctor, so I agree with Dr. Gufran that we should use intravascular imaging first. So maybe an IVUS, because considering that this is a very tight lesion, so although not angiographically seen, it might be it might have a very severe calcification that we might need to do lesion preparation first before stenting, such as maybe atherectomy, orbital or rotational. And then I agree with Doctor. We can do DK crush since relative to the main branch, so the side branch I think has more than 70 degrees angulation, and this is a complex lesion, so a DK crush may also be useful, Doctor.
So we welcome Dr. Florim from Switzerland joining us. Dr. Florim, when you do intravascular imaging, can I ask you, what is your preferential intravascular imaging technique for this case? You're muted, sorry. Maybe you can unmute yourself, please.
Well, to be honest with you, my initial technique is actually OCT all the time, but sometimes I have to use IVUS. Also in the case I will show you later, I used IVUS, but I try to use OCT whenever I can, and if it's not possible, then I use IVUS.
So Jion and OB-Van, can we switch over to Cam 4? We had, I saw you had some OCT runs in the diagonal LED. So Jion, if you can help us through what is found. OB-Van, can you unmute him? Sorry, I still don't hear Jion.
Okay. Can you hear me?
Now we can hear you. We can see you too. Go ahead.
Okay, so the first OCT run was into the diagonal, but the diagonal, as you could have told from the angiogram, is very tight, so the blood clearance is not great. But nonetheless, we have some assessment. So this is when I'll just show you the OCT, which you can see here. So going proximal to distal. So this is the guide catheter, 3 wires, one in the circ. So that's the circ at the 7 o'clock position.
6.
Sorry, that's not the circ. The circ is the one at the 11 o'clock. So the first wire goes into the circ, and now we're in the LED. So the second wire will go into the diagonal. The diagonal will follow straight on because this is the diagonal. So LED is the one in the 7 o'clock position. So you can see this is after POBA. So there's a lot of dissections already. All dissected. So the purpose of this OCT run into the diagonal initially was to assess a couple of things. One is maybe the distal vessel size and then the lesion length. In terms of plaque morphology, it's quite difficult to assess after POBA, but we can see that there's not a lot of calcium, maybe a little bit of a chunk here and there, but otherwise it's mainly fibrous plaque. Here there's some calcium again from 12 to 4 o'clock, but otherwise it's not too bad. So because the blood clearance isn't great, sometimes the vessel size can be underestimated if you try and do a measurement this way. Nonetheless, we made a measurement here. This is the distal, where we think is the distal landing zone of the diagonal, and measuring from the external elastic lamina to the external elastic lamina, it's about 2.25 millimeters. So if we measure that, that's the distal landing zone. So we definitely don't want to implant a stent that's bigger than this.
12 down.
And I think Aaron's strategy here was to try and use a Q-lot if possible. Down. So we'll have to measure the lesion back all the way into the 12, LAD. 14, 16. So if we take that length from the LAD here to the distal, it's actually about 30, 31. Yeah.
This is 15.
Yeah.
15.
So maybe you can get back to Aaron later. Is your preference to use one stent and crossover, or you're going to use two stents based on what you see on OCT? Jion, what?
2,000. 2,000? Yeah.
I think because of the limitation in the lengths of the stents available that we want to showcase today, it's going to have to be two stents in the diagonal. So one stent from the proximal to further down the diagonal, and then a shorter one from LAD to the diagonal.
Yeah, use that.
Yeah.
Any other comments from the faculty about what is seen on the OCT? Maybe you can go quickly to the second run as well. Are you showing us the OCT in the LED as well, or no, Jion?
Please, yeah, sure. Because yeah, go ahead.
Okay, so this is the OCT from the LED. At this point, the circumflex wire was already removed, so we only see two wires here. So this is the guide catheter. So the diagonal wire is the one that's going to disappear towards the 7 o'clock position. Okay, and one tip perhaps is to, when you identify the circumflex, in this case we don't have the circumflex, so we have the diagonal. Diagonal kind of branches out in the same direction as the circumflex when you look at imaging from the LED. So one tip is to go to your settings and go to the rotation, which is here, and position it such that the diagonal wire or the circumflex wire disappears towards the 9 o'clock position. By doing that, when the circumflex or the diagonal goes towards the 9 o'clock position and your LED remains in the middle, by doing that, you orientate yourself so you know anything at the top 12 o'clock position, that's the epicardium, and anything down here in the 6 o'clock position is the myocardium. So septal branches should go down towards the 6 o'clock position. So this is the assessment from the LAD. So again, moving from proximal to distal. Here it's all disease, so it's very difficult to make an assessment of the proximal vessel size. And then here we see a lot of dissections because the LED also has been pre-dilated already. So mainly soft plaque, looks lipidic over here. Lipidic because it's dark, it's not well defined, and there's a lot of signal attenuation. So there's a lot of signal loss as the OCT penetrates through the plaque. So a lot of lipidic plaque over there. Maybe a small bit of calcium here where the shadow is a bit more well defined, but mostly soft lipidic plaque. As we go further down, here the vessel was not yet pre-dilated. There's a branch there going down 6 o'clock, so that's a septal branch. And if you, I guess you can't see the angiogram, but this helps us to orientate whereabouts we are in the in the vessel because we don't have the angio co-registration function on our system here. And yeah, this is the distal landing zone. Okay, so in terms of sizing for the LAD, this is the distal landing zone. So again, we do two measurements here. The vessel is relatively normal, so we can see the external elastic lamina. So we take two measurements in orthogonal planes. So that will give us, so one measurement from external elastic lamina to the external elastic lamina. So that's about 2.66 in that plane. To 3.0 on the other plane. So on average, that's maybe about 2.8, 2.75, 2.8. So that's our distal landing zone. So we can pull this marker here where I'm moving my mouse. That will land us at the distal landing zone. Again, the lesion is quite long. So the plan is to do 2 stents in the LAD. So we can pull the proximal marker to where we want to land it. I think we'll want to land it proximal to the first big septal. So that length is about 21 millimeters.
Sorry, 20?
21, 22, if they have something in that range.
So thanks, Jion. That was a great narration. Can I go back to my faculty?
I'm going to deploy the diagonal stand now. So what I did is,
can we switch back to,
because the lesion is very long, so this ultra biofreedom, at the moment, they don't come in 2.0. The smallest stand is 225. So we sort of try to squeeze in a 225 in this probably 2.0 vessel. The first stand is, we can later discuss about the features of this biofreedom ultra. So this is a 225/29. Yeah, so deployed at the nominal pressure and then post-dilated. And then this is the, not too bad. I think 225 fit quite well. So I use a 225 NC balloon to post-dilate and then use it to measure the length. So it looks like probably about slightly more than 15. Huh? This is 15. So I use a 19. So this is where we are now.
Thanks, Aaron. So just to let you guys know, this is the new Biosensor Stand, the Biofreedom Ultra using the cobalt chromium platform, similar to the Biofreedom Stand, but non-stainless steel now. This is actually the first live case implant in Asia, actually, in Sengkang Hospital. So later, Aaron may want to narrate out the characteristic of this stand. Can I just ask maybe my faculty, Kwang, did the OCT actually help you with strategy at all, you think? We have done it without imaging.
14.
I think it's important because it can show that there is not much calcification in the lesion, and then we can for this case we use some certain side of the stand, but usually in the practice we can put a longer stand, and then putting a stand is delivery the stand into the target lesion is the problem if there is a lot of calcification, and also there is a too complex bifurcation at the same time. So I think imaging is very important, and OCT actually show what the calcification lesion.
Any tips and tricks for the faculty in performing OCT in the left main position? Anyone?
So I think, Jack, when you image the left main, your biggest caveat is that it's not so easy to look at the ostium of the left main, and some people have described using a guide catheter extension to image the ostium. But the other issue with the imaging the left main is sometimes you don't get a good idea of the size of it. But by and large, they tend to be quite similar. One thing that we in our lab we've found is that when you inject, if you undo the manifold and inject right into the TUI, you seem to get better image quality. So that's one thing that we recently learned. At least, actually, I learned it from my colleagues. And so that's one tip. The other tip would be that the OCT now comes with the good angiographic core registration. If you have that package on your software, and that will tell you exactly where you're looking at, so you don't have to imagine the core registration. You can actually do it.
Anyone has experience using a guide extension for OCT in the left main position? My understanding is that the telescope is touted as the one that you can see through the distal tip. The rest of the guide extension actually helps you deliver it right. The ostium, you can pull back the guide a bit, but you can't see through. Yeah.
Right.
So
that's what I was alluding to, the telescope.
Yeah. Okay. So if I may, Aaron, I think this case is truly a bit complex for fellows teaching, but a good job so far. I'm going to leave you a little bit. I'm going to move on to Fahim to give his lecture first. Then we'll come back to you to discuss the case proper. So Obi-Man, can you stop share so we can have Fahim then add on to the discussion on who, where, and how.
Mute.
Fahim, you're muted, is it? I can't hear you.
My apologies. Can you see my slides and can you hear me?
Yeah, I can see your slides. It's just not on full screen. Yeah, now it is. Go
okay,
ahead.
And you all can. Sorry, there was some glitch on my side. So, thank you, thanks Jack for the invitation to talk here. So my job is sort of relatively more mundane, but it's important for fellows to understand the data behind left main stenting, and so it sort of will hopefully try to tie in everything. I'm just going to talk briefly about a case and sort of take a case through the decision-making in left main stenting. So this is a 71-year-old man with the usual risk factors who comes with stable angina despite a lot of anginal medications. And an angiogram shows what we kind of all expect to see, a severe distal left main involving the ostium of the LAD and the circumflex, pretty critical disease. So you then, and the right was okay. And so you then offer him options for treatment. And the patient is a pretty intelligent guy, and he asks a whole bunch of questions. And I'm going to take you, at least take the fellows very rapidly through what the patient's questions are and how you would propose to answer them. And so his first question is, well, can I be treated medically? And so you have to answer the question, is left main a medically treatable disease in 2020? And, there's a lot of stuff out there on medical treatment. But this has not been very well studied, believe it or not. The ischemia trial excluded people with left main disease. And the only data that's out there that's relatively recent is this sort of a network meta-analysis that basically suggested that medical treatment isn't a good option for left main disease. And so I would answer that, can I be treated medically? The answer is not likely. So he then asked the more important question is that, will I live longer with bypass surgery as opposed to a PCI? And this goes to the question that does cabbage for left main disease reduce mortality? If you go back to the data, now this is relatively older data using a lousy first generation stent, but the Syntax trial left main subgroup that was pre-specified in the trial, 5-year outcomes for the left main group actually showed no difference in mortality. Sure enough, there was a difference in revascularization, but no difference in mortality, unless you looked at the group that had a very high Syntax score, more than 33. And this goes back to the original comment I made that when you have really complex disease with left main disease, it's a different ball game. And if you then go forward to the 10-year follow-up, so even way down, 10 years down the line, left main disease, with using an inferior stent, there was no difference in mortality at 10 years. There was a difference if you had 3-vessel disease, but for left main disease, that did not hold true. If you then fast forward to the more modern trials, the Excel and Noble, which was specifically studied in left main using the similar endpoints, but less complex disease, Syntax score less than equal to 32, or the equivalent of that in Noble, using relatively more modern stents and more modern techniques, including IVUS in about 75% of the case. If you look at the Excel trial, which was just published very recently, the composite endpoint at 5 years, no difference. When you look at it more closely, the myocardial infarction rate was also similar, although there was increased early MIs in the cabbage group and a reduction in late MIs in the cabbage group. So cabbage was worse for MI initially, and then spontaneous MIs were less frequent. And then there was a mortality signal suggesting that maybe there's a reduction in mortality with CABG. Now, when these results came out, and I just sort of highlight this again, in CABG, there was an increase in early MIs and then a reduction in spontaneous MI, and a suggestion that there was a decrease in mortality with CABG. And when these results came out, it created a whole, storm in cardiology, which we don't have time to go through in detail. But certainly for the fellows listening, a lot of allegations were put forward that, well, for starters, this early MI signal in CABG was really not fair on CABG, because the early MI is not important and the late MI is important. But that may be true, but the definition of these early MIs was defined as large MIs. CKMB is more than 10 times the upper limit. This was pre-specified, unanimously agreed upon. And this was done to reduce what is called ascertainment bias. And what that basically means is, if you don't look for something, you won't find it. So for example, CABG patients, when they complain of chest pain, it's often thought to be incisional or not looked at. Sometimes they're intubated, so they can't speak, or they have bandages and they don't get EKGs. And so they chose a large MI pre-specified as an endpoint to see that, well, what happens to patients when they go through each procedure. And these large MIs in Excel were actually prognostic. They saw that only the large MIs in the Excel trial were related to prognosis, whether it was during PCI or whether it was after CABG, versus the small troponin leaks or CK leaks were not that prognostic. So this criticism was relatively unfair. A more important criticism was that the mortality signal was kind of ignored, and that's not really true. Because what happened in Excel is that all-cause mortality was an underpowered endpoint. And whenever you have underpowered endpoints, there's always a possibility of chance. There were about 35 secondary endpoints, and there's always a possibility of a chance finding. But more importantly, there was really not a lot of biological basis for the mortality signal, because when they looked at it more carefully, all of these excess of deaths in the stent in the PCI group were due to sepsis, cancer, in other words, non-cardiac. So if you look at the cardiovascular mortality, that was similar, whereas these non-cardiovascular things like infection and sepsis were more so in PCI, possibly raising the question of chance. But I think mortality is mortality. And so meta-analysis data also suggesting that no difference in mortality between CABG and PCI. And then a more recent meta-analysis again suggesting that the risk of death, when you look at all the trials together, including Excel, Noble, Syntax, 10-year follow-up, and pre-combat, no difference in mortality, although the risk of revascularization is clearly higher with CABG. And so, but there are also opposing viewpoints. This is a meta-analysis of network, a Bayesian meta-analysis, where they suggested that no, maybe the mortality signal is important. So there's a bit of a controversy on this. And so what do you tell your patient? And this is what I tell my patient. I'd tell the patient that you don't have super complex disease. So the mortality is at best similar, at worst slightly higher. And so at 5 years, your chances of being alive is 87% with PCI and 90% with CABG. And that is the honest truth. That's what the Excel trial showed. And then let the patient make a decision with you as far as mortality is concerned. And certainly this consideration is important when you're 50. It's less important when you're 85, but every patient is different. So you have to have that shared decision-making with the patient. So then they ask the question that, is he going to live better with CABG? And there's beyond a doubt, CABG is much superior to PCI in terms of repeat procedures, but the question is how much, and is it just really the cost of doing business, or is it really too much? Is repeat revascularization really a huge problem? And so these are the numbers from Excel. When you have repeat revasc, it's about 17% at 5 years, versus with CABG, it's not 0, it's 10%. And keep in mind that about 6.5% of post-bypass patients have the equivalent of stent thrombosis, which is acute symptomatic graft occlusion. And so what I tell my patient is that at 5 years, the probability of you being free of revascularization is 83% with PCI and 90% with CABG. But keep in mind that at 5 years, you have about a 4% chance of needing to go to CABG if you've had a PCI. So a lot of patients worry, they have had a PCI, am I going to inevitably need bypass surgery? That number at 5 years is about 4%. So our patient is smart. He then asked the question, well, who should do my procedure? Should you do it? Should some other guy, a smarter guy like Jack Tan do it? And the answer is, this is from very recent data published from the British Heart Foundation, the British Cardiovascular Society database, published by Tim Kinnaird, that there is a threshold number of left main PCIs that operators need to be doing before you can say that they are proficient. And that magic number is around 16. So let's say 16 to 20. And so the answer to the question is, yeah, the person who should do your procedure is the one who does left main PCI frequently. So left main PCI is not meant to be done by somebody who does one a year. That's the bottom line. Well, how should my procedure be done is what he then asked. So this is a really smart patient. And this is where some of the discussion we've had already, that imaging is extremely important. There are no randomized data, but there are certainly very potent observational data, again suggesting time and again that there is a mortality benefit with IVUS-guided left main PCI. And the difference can be as much as 5 versus 16%, but clearly there is a mortality benefit when you use IVUS-guided PCI. And so I would strongly tell the patient, and then the other question is what technique, and this is something we've already discussed. The data would suggest that DK crush is better than culotte if you are choosing, but obviously a lot more goes into the decision as to what kind of procedure, what kind of two-stent strategy you use. And also there's suggestion from the data from the DK crush 5 that versus provisional two-stent strategy, if there's circumflex disease, is probably the better way to go. And very recently, the definition 2 study was published where they had about 30% of the cases were left main, again suggesting that two stents, mostly DK crush technique, is better than provisional for a reduction in TLR, target vessel MI, and target lesion failure. So I would tell the patient that your procedure could be done provisional when it's feasible, but you need a good two-stent technique if needed. DK crush may be better if your operator is proficient with that, and imaging will have an outcome on mortality. I think, what do the guidelines say? Well, this is important. The US guidelines are quite dated, so I'm going to just focus mostly on the European guidelines. And in the 2014 guidelines, they suggested that actually, excuse me, they gave a class 1 indication to left main PCI when it's less complex and a 2A indication when it's intermediate complexity. But uniformly, both sets of guidelines will say complex disease with left main, don't touch it. And the most recent guidelines that were updated in 2018 suggest pretty much the same as far as this is concerned. The appropriateness criteria will also uniformly say complex disease, don't touch it. But if it's isolated osteal or if it's mid-shaft disease, fix it with PCI. And then for the rest, if it's less complex, it is possibly okay to use left main PCI. I will say that in the world of trials, trials typically look at patients who are okay for CABG and okay for PCI. But in reality, patients are often a lot different, like the patient that Aaron is working on right now, where in reality, they are often patients often have a lot of comorbidities. They're too sick, too frail, or the procedure is too risk. And they often move from CABG to PCI, even if they have surgically appropriate disease. And then a lot of patients, who are kind of, okay for PCI, but they have a lot of comorbidities on their own, and sometimes they are best treated with medical therapy. So again, shared decision-making with a heart team approach is the way to go. So if I was to conclude, ladies and gentlemen, PCI and CABG are treatment choices that patients and physicians have to consider for left main disease currently. They are both treatment options. Surgery is an awesome, robust treatment option for left main disease patients, especially when the disease complexity is high. There's no question about it. Recent data suggested that PCI for less complex disease offers an alternative, and the gap between PCI and CABG has considerably bridged. The mortality signal, I would say, is either equal or slightly increased, and it's important to put it to the patient. The way I suggested. What are the probability of you being alive at 5 years with PCI versus CABG is a good way for patients to understand what their options are. But you have to accept, if you're going to go for PCI, that there will be an increased repeat revascularization rate as a price. And it's important to understand that optimal technique is essential. Left main PCI is not routine PCI. You need high volume operators, image guidance, lesion preparation, the right way, FFR guidance when needed, mechanical support when needed, and appropriate antiplatelet therapy. And decision-making sometimes involves incorporating a lot of information that goes beyond the coronary anatomy, like the patient you're seeing right now being done, which includes patient comorbidities, frailty, as well as patient wishes. Thank you very much. I'll be happy to answer any questions if there are.
So Fahim, that was amazing, actually. I thought the way you put it across in the patient consult was very balanced, and I like the way it was very presented based on data. I have a question from the audience calling in from Margin Van Murik. I hope I haven't macerated your name. Are there more specific patient characteristic to predict the difference between CABG and PCI long-term results? I guess long-term defined as 5 years and above. Maybe I'll take a pause from Fahim. I'll get the opinion from Cheem. Do you have any guidance to this question?
I think two features often stand out in the outcomes between PCI and surgical revascularizations in patients with left main and perhaps multivascular coronary artery disease is that number one is the complexity of the lesions, and it's quite obvious from the syntax score that when you have very complex lesions, 32 and more, you find that you actually benefit more from surgical revascularization than PCI. And the second thing that always stand out again in the trial is the comorbidity of diabetes mellitus. And somehow diabetic patients seems to do worse in Barry trial from the very beginning to even syntax sub-analysis to freedom trial telling us that CABG seems to be better than the PCI. So I think for these two categories of patients, but actually, I would also add on LV dysfunctions being someone that I will favor a surgical approach than a PCI for its longer longevity. So I agree with Fahim. So you need to have a shared decision making with the patients, and certainly when you have a very simple left main or SPEC score low, like in the Excel trial, there are trade-offs. There are trade-offs in terms of early MI with CABG versus more revascularization with PCI in the later part. So
I think the low EF is kind of almost a kind of a double-edged sword in its own right, as Cheem said. For a lot of patients with low EF, surgical is a good option. But sometimes when the EF is so bad, the surgical risk goes up so high that we are often asked to fix these patients, and then we have to bring in the issue of mechanical support. And again, that's where, as Cheem said, the discussion becomes exceedingly important.
So coming from Europe, Dr. Florim, Noble versus Excel, Fahim presented some data. Are you concerned about this somewhat controversy of the Excel data, or you think the data is what it is? You're muted, sorry.
I think I liked a lot the presentation, and I think we have to, on one side we have the data, but what we also have is the patient wish, and also smart patient, increasingly patients who want to discuss their fate with us and who want to decide on their fate. And actually the case I will show is exactly such a case where you can think, well, this is actually a surgical case, but in that case, the patient just didn't want that. And you can take him off the table and you can just reject him, but then he will probably look for another doctor doing it. So I think we have to respect this data, but we have also to see to discuss the situation with the patient. And at the end, if the patient says, my wish is to just have zero or less, you're not zero, but less chance of coming back. We have such patients. Then for a case with a very calcified left main and syntax score of 35, yeah, I encourage surgery, of course. But if the patient says, listen, I don't care if I come back, but now I'm 55 and I want to work a few years fully in, he has good reasons for that, then we respect that and we treat it. So I think I would not see this very dogmatic. Sometimes guidelines are just interpreted in a very dogmatic way. And I think we are still doctors and we have still patients' wishes. So we have to be much more pragmatic with this data. We can't ignore them, but we just have to be pragmatic.
Thanks. Any comments from my faculty on this who, when, and how? So Ramesh or Joel, can I ask, what do you get a sense of how many left main PCI you need to perform before you are one of those operators, you think, or is it pure outcomes?
No, I think the data that Fahim showed actually is fantastic, and regard whether it's bifurcation CTOs or even left main, you have to be, in order for you to convert yourself from a fellow to a consultant, you have to do a significant number of complex cases. That's one. Number two is I realized that when I became a consultant and I had to teach my fellows, I also learned as well. So because you take on a responsibility, you become more vigilant, you become more caring, more careful, because the responsibility is now upon you. As last time when you compared, when you're a fellow, your consultant was covering you. So I think this is a learning process. You would have to just continue to do to do your cases. The thing about left main is, unlike CTOs, where I mean the problem is perforation at worst. If your left main goes terribly wrong, the patient can lose his or her life on table. So I think 16 per year, I think, is important. Bifurcation two stand provisional, two stand techniques from the beginning is also not many that we see each time, and we don't even do it many per year as well. So if you want to do, I think like what Prof Tan said just now, at least know one stand technique better than the rest, rather than knowing several two stand techniques in a mediocre manner.
Thanks, Ramesh. And from Jaw, if you're talking to your fellows, can you give a simple message about your advice? What type of left main cases should your fellows start off with?
Normally left main, left main or body of the left main disease, that's quite simple to do. Normally, fellow or very junior interventionalists, they should start with the septal lesions. And then the body bifurcation left main, they should start simple. And then if they are quite confident to do some complex bifurcation techniques, they can start with complex left main lesions. And think we have covered a lot of procedures and precaution in the left main PCI from all the faculties. I think one thing we need to think about is when the operator to start with the hemodynamics support or just stand by. So can I ask Professor Huay Chin, so when you consider this patient needs maybe PCI with hemodynamic support or just stand by in case, so what are the precaution points to need hemodynamic support backup? Thank you.
I remember long ago there was this BCS trial that's looked at the high-risk PCI and patients with impaired LV functions on the need for mechanical circulatory support. It turns out that you don't need if your patient is relatively stable. So I think if your patient has impaired LV but is very well compensated, stable, I think if you keep your procedure safe and short, it should be okay. But when somebody has got very recent heart failure, decompensated state, and has got very, very poor EF, less than 20%, and is symptomatic, I think some form of mechanical circulatory support will be helpful here. And now IBP is obviously the first choice, but I can say that increasingly in my center, if you are under the age of 60, we will do an impeller supported high-risk PCI for you, just because you're young.
So I didn't want to go into that topic, Cheem, because it's another topic for full discussion. So I want to go back to the cath lab now in the interest of time. Obi-Wan, can we switch back to the cath lab?
We have a 3-0 90 balloon.
So Aaron, are you okay to share with us the progress, or you need some more time? Right.
Yeah, I just share with you what I did. So remember just now when I did the placement of the diagonal second stent. Yeah, I placed it somewhere here. Can you show the other? Yeah. So
there's a gel balloon, Aaron.
1.5 balloon as a gel balloon technique, just in case that the LED get occluded. then we can convert it into a crush. So this is for cases where the LED is very tight or there's a dissection that you worry that you may not be able to wire through. That's the problem with the collapse, because you may have to, possible that you may lose a branch. So we deployed it, post-dilated, and then the LED looks fine actually, yeah. So in this, usually what we usually do is we will pot it, yeah. But I just worry that when we pot it, the LED will get compromised more. So what I did is I removed the a balloon, 1O balloon, and then just use another wire to rewire the, we post-dilated, pot it first, and we wired it, yeah. And then the 1.5 balloon went in. And then
so it means that do you switch the wire across, or you use you just pull back?
No, I didn't switch actually. Yeah. I use a new wire, yeah, because I want to keep the LED secure, just in case that we can't wire the LED, we can always convert it to a crush if needed.
So this is kissing. First is a double kiss Culotte technique you're demonstrating.
Yeah, double kiss Culotte technique. This is probably just to make sure that the side branch, the further corner doesn't get pulled back when we inflate the main branch. Because if it got pulled back towards the main branch, then when you wire it, sometimes you may inadvertently wire underneath stent struts. Yeah. So I think that is the advantage for this double kissing Culotte technique. So we post-dilate individually, and then we dilate both, yeah. So we put a 2.5, 24. Yeah, just distal to the diagonal. There's some spasm in the distal LED, yeah. So we deployed it, post-dilated, and then we were just working out what's the length of the left main to LED stent. But because the guider doesn't engage very well, and the left main was very short, so we actually did a few rounds of OCT with the telescope. Hopefully that we can see the thing. But okay, Chieh, can you show that?
It's good to share. OB-Van, there's some static coming from Aaron's mic now. I'm not too sure why Aaron is rubbing against something. Is it your mic? So Jion, can you show us the effect on the telescope, and what is your guidance for this?
You can hear. This is the OCT after stenting of the mid LED port.
Sorry, Jion, can you hold for a while? Or OB-Van, there's some static coming from Aaron's mic, or is it someone's mic? Okay, go ahead, please.
All right. Okay. So this is the distal landing where the 2524 landed. So it's just at that big septal, so that's okay. So this is before post dilatation. Anyway, what we wanted to check was the length, of the neck stent from the left main to the LAD. So the left main ostium wasn't very well seen. So we tried to use OCT to help. So this was so we used a couple of techniques. So this is the technique where during the pullback, Aaron tried to time his catheter withdrawal, his guide catheter withdrawal, just perfectly in order to try and catch the ostium of the left main with, as the OCT catheter is traveling back. But as you can see here, it's very difficult to time that catheter withdrawal. So he withdrew the catheter maybe a little bit too early. So this is all the blood, and you can't really tell what's going on in the left main. So that's the limitation of this guide catheter withdrawal technique. So then we tried to use the telescope. So as you know, the telescope is a guide extension catheter. And one of the features of telescope, which is it's not exclusive to telescopes, so I'll mention later, some of the other guide extension catheters can do it too. One of the features is that even within the guide extension catheter in the 2 millimeter distal tip, you can see through the guide catheter, the extension catheter to assess the outside. So I'll show you here. This is the OCT catheter. This is the vessel. As we come back into the guide extension catheter, this first ring that you see, that is the guide extension catheter. And despite being in the guide extension catheter, we can still see the vessel beyond. But this clear visualization is only for the first 2 millimeters, or rather the distal 2 millimeters. After that, there is this the braiding of the guide extension catheter. So then you get a lot of this metal kind of thing, and it obscures your vision. So it's not very easy beyond the distal 2 millimeter tip to assess the vessel. So you really have to position your guide extension catheter very precisely, just with 2 millimeters or less extending into the ostium, if you really want to catch the ostium. Nonetheless, we can make out a little bit through all this, through the braiding, that perhaps the ostium of the left main is around here. I'm not sure if you can appreciate it, but through the coils, we can maybe make out the left main, the shape of a vessel. So maybe that is the ostium. We made a measurement. So the measurement was about 20.8 millimeters from this possible ostium of the left main to the proximal edge of the mid-LAD stent. Of course, this is not perfect, so I would recommend confirming on other methods, maybe on angiography or other imaging modalities, if you really want to be very precise. Yeah, so I've tried, as an experiment, I tried with other guide extension catheters, and the GuideZilla and Guide Liner can also do this. So the distal 2 millimeter tip is also quite OCT lucent, if you like, so you can see through. So it's not exclusive to telescope. Guide Liner and GuideZilla can also do it. Yeah.
Thanks a lot, Jion. So again, that was a neat observation. I haven't seen this before, actually, although people talk about it. So you can see a little bit of the tip. It allows you to see a bit into the left main, but not that much. The limitation of OCT in osteo left main or RCA. So looks like Aaron is doing quite well, actually, for complex lesion, 2 bifurcation, TK crush, culotte. If we have time, we're going to talk a little bit into that.
Okay, so Jack, so I'm because the OCT can't guide us the exact the length, so we sort of give us a rough idea. So we use a 3019, yeah, 19, just to place it, just overlap with the previous stent. And then on the spider view, it looks like, can you change to the spider view? Just have because the left main, I think, is very short, very short. So, and the osteo left main wasn't diseased. So I think we can probably miss the osteo left main from the previous angiogram. So we deploy here, and then we use a 3.0 NC balloon to pop the proximal LAD. And then this is 3.5 NC balloon to pop the left main. And this is the results. So yeah, 2 more job. One is to kiss the culotte, and the other to kiss the
D1 already. So still quite a fair bit of work to do. Any tips and tricks for how to position stand in the osteo left main for my faculty? Anyone?
One thing I've used fairly frequently is to put what you call an anchor wire, a floating wire in the aorta, not to mark the ostium. That can be misleading, but to at least keep the guide out. And so what you do is you put the floating wire in the aorta, and then you push the guide against the aortic wall, and that can help you visualize the ostium more easily, to know exactly where it is when you're trying to figure out where to land the stand.
Aaron used to do a lot of Szabo's technique, but I think he has stopped.
Yeah, I did. So maybe that's now close to 10 years ago, did some Szabo's, and actually it wasn't too bad, but it was just too tedious, just not worth it.
Any other comments from the faculty? If not, Aaron, I'm going to ask you to OB-Van to stop share this. Just out of interest, you placed so many of this BioFreedom Ultra. I just would like to share some slides on it, if I may. So this stand is the first of the BioFreedom Alpha to be implanted in Asia. So just to keep everyone just updated over a few slides about what's new. So this is the same drug coating technology employed in the biofreedom stent deployed into the biofreedom alpha structure. So the stent architecture now is a cobalt chromium rather than stainless steel. And the differences narrated here, switching from stainless steel to cobalt chromium, the strut thickness has gone down from 114 microns to 84, 88 for larger stent sizes. Open cell, there is a little bit of change in the stent architecture in terms of a hybrid structure. The tail end has some S-shaped and straight links for prevention of longitudinal strains. Otherwise, it's 3 links for all models, 6 and 9 crowns. And these are the stent lengths that is slightly different from the previous platform as well. Similar to the Alpha platform. So the difference between Alpha and Ultra is that the Ultra Biofreedom follows a Biofreedom drug coating, which has no polymer or carrier. So these are just some illustration of the side branch access when it's open up, especially if you're employing this stent for bifurcation. So in the smaller vessel formulation up to 2.25, you can open out the side straws fairly big up to 3.5 above in terms of diameter. And for the larger stent sizes up to 4 and 3.5, with a huge area actually. So the same stent from 2.5, 2.25 to 3.0 can expand to 4.76, and the 3.5 stent platform can stand up to 5.9. So that's probably very suitable for left main location. So just brief data. This was trialed and presented in PCR this year, comparing leaders-free tree trial using this novel 83 micron cobalt chromium stent. And they recruited about 400 odd high bleeding risk patients compared to a historical previous leaders-free one data with the first generation biometrics and bare metal stent. So most of the patients here are the same, elderly. A lot of them actually have indication for anticoagulation due to AF. And the results actually looks pretty decent for safety, cardiac death. All looks slightly lower than the initial bio leaders-free one data. So I want to just quickly go into a little bit into the previous what Aaron was talking about. I found quite interesting what Aaron did actually. So just to rehash a little bit, and then on the double kissing Q-lock technique, this publication came out actually earlier this year from a group coming out of a collaboration between one of my guys in Heart Center as well and the engineering department at NUS. This is a refinement of the Q-lock technique, saying that you can do a double kiss to optimize a Q-lock technique. Kwang may want to comment to that later as well. So in the double kiss Q-lock technique, the time taken actually is sped up if you use this double Q-lock for access into the side branch. So it seems that flow time is less, and the advantage is that you don't have all this crushed, torn in gaps within the Q-lock if you do a kissing before you employ the main branch stent. So the side is better opposed, and you can gain access smoothly in the distal stent strut. And there's some flow computational dynamics, and it shows that actually it does look even better than the decay crush in terms of laminar flow achieved on at least a bench model. So Aaron, do you have any comments on the double kiss crush, or anyone have any experience?
Am I on?
Yeah, you're on. Go ahead.
Yeah. So the thing that I mentioned just now, the advantage is to make sure that the stent straps on the side branch is fully expanded, rather than, because when you inflate the cell, you will pull the stent towards, on the opposite carina, pull towards the main branch. So you lift it out. So when you rewire the side branch afterwards, it may accidentally wire underneath the stent strap. I think that's the only advantage. Yeah.
Anyone has any experience using this? So maybe you can stop share. I just play a quick video for the fellow's sake, just telling them what you are referring to. Sorry, just give me a minute.
Take this one.
LED diagonal.
Okay, so let's do it this way. Which one, the LED?
LED.
So this is a demonstration.
Pot after main branch stenting is very important. After pot, stent struts at side branch is widely open, and it is easier to rewire for side branch. If you don't do pot after main branch stenting, it is difficult to rewire for side branch, and it causes a potential risk to pass the guide wire under the stent struts. If you do proximal rewiring followed by kissing balloon inflation, it demonstrates stent struts overhanging at carina. It causes a potential risk for restenosis in the future. You should try distal rewiring after pot. Then, ideal kissing balloon inflation demonstrates no struts overhanging at carina. Your side branch ostium is widely open.
So thanks to Dr. Takashi and his bench demonstration. That was quite useful. I think it gives you a visual note of why you need to do a distal wire or close to carina wire crossing in a culotte technique. The DK crush as a refinement, the DK culotte as a refinement is probably useful because it straightens out before you lay the main branch stent. And Kwang, do you have any comments on the technique?
I just emphasize or highlight the importance of the pause after you do the final kissing. So you think that it is a final kissing, but actually after you do the kissing balloon at the last step, the stand in the main branch is sometimes still in malposition, and sometimes you sit the carina into the not very good way in terms of shear thread. So that's why after you do the kissing, usually you need to finalize the whole procedure by the last pot. And the last pot is position of the pot is already mentioned by the Professor Cheem. The marker should be at least at the carina of the bifurcation, and then you can keep the shear thread in the very good physiology pattern, and also you make sure that the stand in the main branch is well positioned. So I just add one comment like that.
Thanks, Kwang. Just some Q&A I saw commenting on Fahim's comment and talk. Fahim, which wire do you usually use as a floating wire? Any specific wire? And back to the live case, any tips and tricks to avoid wire wrapping in complex PCI and 6 French guide?
So I think I answered that in the chat group. I mean, basically any wire would do. I tend to avoid the hydrophilic ones because they tend to sort of slip and find their way across the aortic valve into the LV. So other than a really hydrophilic wire, any wire would do. You're just trying to keep the guide outside the left main ostium.
Thanks. Huay, there's one more question. Maybe you take that. Any preferred stand for left main stenting? Or do you think all current third generation stents are similarly terrific for the left main? Sorry, I asked you to answer that.
I think any stents that can fulfill the following 3 criteria will be appropriate for a left main stent. One is a stent that has sufficient radial strength that can oftentimes, particularly in osteo stenting where you're overcoming the resistance from the aortic wall. So you need a fairly good radial strength stent. And I think that ultra thin stent perhaps not as been as good in a very calcified osteo left main lesion. The second feature is that this stent needs to be able to be expanded to a large diameter. So when you have a main vessel and a branch that has a significant mismatch, to have a bar freedom ultra to go up to even a 5.9 millimeter is something that could be very beneficial. And the third aspect of stent will be its side branch protection and accessibility, and this we have talked about. So any stent that provides big access terms of cell space and diameter will be again something that will be favored. So any stents that can do these three things, preferably a second generation stent, I think will be just good. In fact, if you look at the Noble and Excel trial and looking at bar alignment stent versus everolimus coating stent, actually the performance in 5 years is the same between these two. So the stent didn't come in as a feature in the difference in outcomes between that you observe in these two trials.
And Fahim's point is that probably the operator and the technique counts more than the stent currently. Can I then allow my fellows to ask some questions? Sorry, I couldn't get back to you earlier. Any questions from the fellows in the panel? You're good? Don't be shy. Yeah.
So I want to just ask, what should be the stunt size when you're in the main vessel, when you're planning, because you have to do port and you have certain balloons which are size balloon which are available. So what should be the size? The other question is, when you're doing kissing balloon inflation, what should be the inflation? How much high we should go while doing the kissing balloon inflation? And should we do only with a non-compliant balloon, or can we use the semi-compliant balloon?
So all three excellent questions, I must say. Anyone want to have a go?
I can help with the kissing balloon. In general, if you think what is the objective of doing kissing balloon, the primary objective is to adequately dilate the side branch ostium, whether there's a stent there or you're just doing provisional. And so I tend to use non-compliant balloons. If there's a stent, for sure, you go 1:1 high pressure in each. So 20 atmospheres in the diagonal, come down 20 atmospheres in the LAD. And then the kissing part needs to be at very low modest pressure, like 8 atmospheres. Because the purpose of the kissing is really just to reorient the geometry back to a circular vessel from an oval-shaped vessel. That happens as a result of the original kissing balloon inflation. So if you keep those principles in mind, you should be all right. If for some reason you cannot get a non-compliant balloon to track and go, then sometimes you will use a compliant balloon, but that's generally less optimal.
Any additional comments?
I think I echo Fahim's point. For kissing balloon, usually I think it's important to do a sequential dilatation first at higher pressures on both branches. And then my preference is just to go to nominal pressure on both for the kiss to, as what Fahim said, just reconstruct the carina. On a related note, I think, Gufran, you asked about the POTS. So POTS, I think, is an essential technique in all bifurcation strategies, whether it's provisional or 2 stents. And so we should actually size the POTS balloon to the proximal vessel size 1:1. I think whether it's a non-compliant or semi-compliant is less important, but sizing it to the vessel is more important. And the other point is that if you deploy your stents, you have to have enough stent length proximally for you to do an adequate POT. So this is important because your POT is meant to prevent crossing behind the stent struts, make sure that the proximal stent is well opposed, and it also facilitates the side branch access, especially if you want to do a distal wiring. Yeah, so POT is essential. It's an essential technique.
Okay, so again, 3 great questions and very good answers. Maybe ask Huay a last one. There's always a question by fellows. Today not asked though. Is there a disadvantage in extending the stent closer to the ostium actually? Because if you have usually a short left main and you want to do a kissing, you have some issues with port and kissing. So what do you think are the considerations when you want to, how long should you stand back into the body of the left main, even if it's not disease?
My take here is that if the ostium and the ostium of the left main is really not diseased at all, and it's of sufficient MRA, you really don't have to go all the way to the ostium. I think you just need to find a normal segment in the left main where you can position and land your stent. I think that will be sufficient. But when you have diffuse left main, I will definitely cover all the way to the ostium. And just now we were talking about a little bit of techniques of osteo left main. Actually, oftentimes I don't use XB guide because it's very difficult to disengage the guide for left main osteo. I tend to favor the Jakin's short tip so that I can position it nicely. And I can actually put a second wire, like body wire down the same vessel or the different vessel. And that way you can actually back up your guide and allow you to position your stent, cover the osteo. So, and the positioning should really be an RAO caudal, a cranial or LAO cranial, depending on anatomy of the vessel. So these are just some of the things that I would do.
Thanks a lot. So if there are no further comments or questions, I'm going to call upon our last speaker, Dr. Florim, to talk about an adjuvant for, especially, we know this subset a lot of calcified lesions, using ultra high pressure balloon and calcified lesions. Dr. Florim?
Thank you very much. So I have actually here some slides and about highly calcified left main and why I believe pressure is the answer. And today is my birthday actually, so it's also a great pleasure that I can speak to such a great faculty and so great interested fellows on my birthday. I'm very delighted. So first, if you think why PCI fails, then we have to realize that we actually have to deal with mechanical factors. And I cannot underline this enough because this is something we sometimes tend to forget. We speak about stent platforms, we speak about drugs which are applied on stents, but we have to speak more and more about mechanics, because if you look back in this meta-analysis, this was 23 years ago, why PCI fails, it's actually mechanical factors like CTO, ISR, long lesions, and small diameter. These are the factors which contribute, and of course, diabetes. And I think if we want to help our patients, then we really have to give them enough lumen, because if the more lumen they get when they leave the cath lab, the better their outcomes will be. If we leave them with under-expanded stents, they will be back. And I think that's not a good thing. And then we lose, and then we will keep losing our trials against the surgeons. Also in the era of modern drug-eluting stents, stent under expansion, I think remains the main factor why our stents fail. And now we are very excited to participate in the Illumian 4 trial. And I really am excited to see the results, because now we have finally a trial where we aim for lumen. And I think this will answer the question if with more lumen we can achieve better outcomes. Now, if we want to achieve better lumen, I think it's really important that we also use the right kit. And one balloon which I fell in love years ago and which I use every day is, of course, the OPNNC balloon, because this balloon allows me to go to very high pressures and not expand my diameter to regions where I can rupture the vessel. So I've been preaching more and more in my talks and also in our cath lab. Let's go to higher pressure and less diameter with a balloon and really try to expand these vessels. And this is, I think, quite important, because when we use a semi-compliant and non-compliant balloon in a calcified lesion, then we have to know that the balloon will expand into the soft part of the vessel and will not really crack the calcium. And very often in such cases, then we tend to use the bigger balloon and then we rupture the vessel. So if I think back in my early days, when did I have perforations? It always when I was using more diameter in cases, and then I suddenly it bursted. Now, I have here a case of a lady who is 70 years old, and I angioed her 2 weeks ago with typical chest pain. So this lady presented with this really highly calcified left main stenosis. I don't know how you can appreciate, but it's really a calcium nodule. And of some disease in the proximal LAD. She was known to have a previous infarction in that marginal branch. And this was her right coronary artery. And now, Jack, I don't know if we can do a survey here, what I should do with this patient.
Would anyone attempt a PCI straight, or is a heart team discussion again?
So who would go for a straight cabbage, and who would say, well, PCI is feasible?
Yeah, I think in the interest of time, maybe we'll go on, but I would say a Lima LAD would be a good choice, even as a mid cap. Yeah.
Yeah. So that's what I also thought, and I called the surgeon, and he spoke to the patient, and then the patient declined. She said, "No, I don't want this. I want stents because for her private reasons." So the surgeon then came back and said, "She doesn't want surgery, so you have to do it." So we then planned her 2 weeks ago, 2 weeks later, this was a Friday evening case at about, this is now about 8 or 9 p.m. And so I used a 7 French guide. We went femoral, and in this patient, her ejection fraction was about 45 to 50, but I was just very scared of this big calcium nodule, and I knew I have to work hard there, so I put an impeller up front, and I used single access for this case because I knew I will run maybe into some trouble in this patient. So, and then the first thing I did was, of course, imaging. This is now a pullback from the LAD back into the left main, and it will take a while, but I can just skip it because the problem is here, sorry. And then it's just a chunk of calcium, and really imaging here doesn't help a lot because I know it's a big calcium nodule there. And then I said, okay, well, fine, we'll have to deal with this. So what I initially used was a rotablator. So I took my biggest burr, it's 2.0, and rotablated this several times because my hope was to really weaken this calcium nodule in order to be able to expand it a little bit better. And then the problem was then I tried to expand a 4.0 balloon in that left main, but the balloon was not expanding, which I'm not showing here. So then I said, okay, well, I use shockwave. So I used a 4.0 shockwave, and I deployed 80. First I started with 1 balloon, and then it ruptured at about 6 atmospheres. And then I went with 4 atmospheres and increased. So I used 2 shockwave balloons in order to really prepare this very well. Fortunately, this also didn't help a lot. And then I said, well, let's go on. Now we have to use a cutting balloon. Let's see if the cutting balloon will do this. So I use a 4.0 Wolverine balloon at 16, 18 atmospheres to really be able to cut this a little bit, this calcium nodule. That cut it a bit, but this still did not inflate. And so then I used an OPM balloon. I took O balloon and I went to 40 atmospheres. And then at 40 atmospheres, you can see the balloon is not completely open, but it's quite well open. And I said, well, that's fine for now. And then I put a 4.0 stent. So I used the 4.0 BioFreedom stent. And actually, I was happy to have BioFreedom here. And this is the stainless steel version, because I believe that I have to use the stent with the maximum radial strength. And I'm truly convinced that at the moment, the stainless steel version of BioFreedom is probably the stent with the most radial strength for in the drug-eluting stents. And initially, I actually did not want to go for a 2-stent strategy in this case. But as you can see, the ostium of the circumflex was then pinched. And then I felt, let's maybe using a double strut in that area where I had the big calcium chunk would be a good strategy to give me even more radial strength. So then I put a second stent across the circumflex. This was then a 4-0 again, 4-0 stent across culotte. And it looks nice. It looks okay. It looks much better than I initially thought, to be honest with you. But the problem was although sorry, let me go back here. So this view here was actually after kissing. So I used 240 balloon. I have now culotte finished, and I have a stent from left main to circumflex and from left main to LAD, the first one. And you can see this is not really, the ostium LAD is pinched, although I kissed with 240 balloon. So I decided in this case to go with a second stent in the ostium of the LAD to really push the calcium away with the second stent layer. So I used a third biofreedom stent here, and which I placed at the ostium. And then I post-dilated that ostium again with a 4-5 open balloon. Then I kissed with 240 ECT balloons, which are fairly non-compliant balloons from the same company, Sys Medical, at about 12 atmospheres we went here. Then I potted with a 5-5 balloon in the ostium semi-compliant. And the patient tolerated this very well. And this was then my final result, which made me quite happy. And I'll show you also the IVUS, and let's go here. So this is now a pullback from the circumflex back to the left main. And I could not, I mean, you know, I was at the end, I don't know what you will say, but at the end I could not, I was basically done because I could not achieve more than this. I tried everything I could. And then I will show you the IVUS run from the, let me just go here, from the LAD to the left main. We put also a stent in the proximal LAD. And I was actually quite happy with what we achieved. It doesn't look perfect. It could look a bit better in the ostium of the circumflex, but it's fairly good. This is now coming back. You can see it's quite nicely open. A bit oval, I couldn't change that, but it's fine. And these are, you can see here on the left side, this is of course the left main, proximal to the, just before the bifurcation. So we have 16 square millimeters. That's more than enough. And in the ostial LAD, where I had this big chunk of calcium with 2 stent layers, which you can see here, I was able to achieve 12 square millimeters, which is also fine, and I was on. Now, of course, in this case, I used a lot of material. And this is the challenge which we also have in a country like Switzerland, where the patient has insurance, but still it's a high burden, because I used here several OPN balloons, Wolverine, Impella, whatever. So you saw all the materials. I use a lot of material, and this is also, of course, an expensive procedure. Now, had the patient had Lima to LAD, it probably would have been cheaper than this. And I'm not sure this is going to hold. I'm excited to hear your opinion, but this is basically what I had to do, because this was the wish of the patient, and I valued that wish higher than the costs I was causing. I'm not, to be honest with you, I would have avoided it if I could, but she wanted this. Now, if I may conclude, I think, as you saw in this case, in highly calcified lesions, very often, even if you use shockwave, even if you use rotablator, even if you use cutting balloons, you will still need pressure to expand the lesions. It's just not true. I have other cases where people have used rotablator and then think they're done. It's not true. You really have to use pressure to expand these vessels. But you should not burst, I'm now speaking to the fellows. So in highly calcified, which does not give in, it doesn't expand, use a proper balloon, downsize the diameter, upsize the pressure, and you'll be fine. Thanks a lot for your attention, and let's see what my colleagues think if this is a completely crazy approach.
Thanks, Florim. Can you stop share your screen? I thought that was an amazing case. I know it's quite investment in devices. I saw impeller, protected PCI, rotablation, shockwave. In Singapore, we say you can die, but you can't get sick because of the cost. So I think this is tremendous. Any comments? Maybe we can use the questions from the fellows. The participants have asked quite a few interesting questions.
Maybe I can ask Florim just a quick question. That's a great case. I mean, I'm just curious, did you, you went with a 2-0 burr, right? So, I mean, with the nodule, the key thing is to shave off as much as you can. There is a suggestion being made that orbital somehow is better for shaving off nodules. I'm not sure. I can't really speak to it. But one thing that's recently been talked about as far as rotablation is concerned is that you do slow rotablation after you've done your initial, you've crossed the lesion and you've done your polishing run. Some Japanese operators, I mean, very extremely high volume operators have suggested to go at about 110,000, and you get sort of a pseudo orbital effect, if you will. And I'm wondering if that's something that may have worked here, because we know shockwave doesn't work so well for nodules. I don't know what your thoughts are on that.
So that's a great question. I'll hold that thought for a while for him as we go back to the lab. Then you can answer that. Obi-Wan, can you go back to the lab, please? There's also a few questions from the panel. We have 5 minutes to go.
Hey, Jack?
Yeah,
Jack?
Aaron, go ahead.
Can you hear us?
Yeah.
Yeah, so when we left you, we haven't done the bifurcation. So we what is this? We recross the diagonal, and then obviously we do a high pressure simultaneous piecing. And then the problem now is we do a pot, and then we cross the circ very easily. But the problem is that the balloon cannot go down. So maybe the panel can discuss what tricks you can use to help this situation. I use an anchoring balloon in the LED, but couldn't cross as well. Yeah. But anyway, so, before that, we did a pullback from the LED to the left main. Can Chieh show the OCT?
Yep. Okay, so this is the pullback from the LED to the left main after stenting from the left main to the LED. So again, this is the distal part of the stent, well opposed, reasonably well expanded. This is here at the bifurcation of the diagonal. And coming more proximally now. So this is with the telescope, yeah? So that's the telescope. There are 2 wires in the telescope, as you can see here. One goes into the circumflex. So here, this is a 54 millimeter pullback, a high resolution pullback. So the OCT, as you might know, has 2 types of pullback. The long survey mode, 75 millimeters, where it pulls back faster. So you use less contrast for a longer pullback length. But there's also a high resolution pullback at 54 millimeters length, but at a slower pullback rate. So you get more sampling per millimeter. So this one we did with the high resolution, slower pullback. And we can see here, we're inside the guide, the telescope guide extension, but we can still see the left main pretty well. So this is the distal 2 millimeter tip. And then here we come to the braided part, if you like, of the telescope. So there's a lot of interference, but you can still kind of make out the shape of the left main as we scroll. So there, we didn't hit the left main ostium, but that's okay, I think. From what we can see of the left main, when we measure the left main, it's eccentric. It's about 8 millimeters square in area. So that should still be sufficient for a left main in an Asian individual. even for Caucasian actually. But so that's okay. So even though we didn't hit the left main ostium, I think that's all right. So that's the OCT pullback and the interesting ability to look at the left main ostium through the telescope guide extension guide catheter.
So Jion, you're happy with the imaging results, or
I think,
any
yeah,
further?
I think we're okay in terms of positioning. There's no left main dissection that we can see through the telescope. I think Aaron's just doing some final touching up with regards to kissing and final post dilatations. But in terms of positioning, I think we're good.
So Aaron,
sorry, can I just ask, are the areas, are you happy with the areas? I thought I saw something like 4 millimeter square in the proximal LED. I mean, was I mistaken?
Well, we can scroll through again. So the lumen areas are the top 20. When you say 4, here's in the guide catheter, so that's not. So of course with OCT, there's this function where you can, where it automatically gives you an expansion, well, tells you how good your expansion is. So at the moment, if we position our reference here distal to the diagonal first, so we are just assessing the mid LED part distal to the diagonal. Expansion is about 78%. So maybe you can do a little bit better there. We try and aim for at least 80, if possible, 90% expansion within the stent. So about 78%, that's not too bad. Proximal to that, it's a little bit difficult. We have to reposition our markers. Yeah, I think if you reposition it, it's, the expansion's about 89, 90%. I think that's okay.
Sometimes you could use the tapered model. There are two modelings. There's a double model and there's a tapered model.
Yeah, so this is the tapered tapered reference model that they that we've set here, rather than the side branch one.
Jion, is there anything at the bifurcations that we can help Aaron out here in terms of stent struts across the ostium?
Yeah, I think from this OCT, because we had the guide extension catheter jammed in right at where the LED and circ, right at that bifurcation, it's not very easy to tell whether on the 2D or on the 3D, which I can show you.
As you can see, the wire went in very easily. Look at that.
Yeah, one of the common reasons is because there is a stent strut perhaps across the ostium of the circ. And
yeah, it's a bit hard to tell on the OCT because of the guide extension catheter being there. So I'm afraid.
What do you mean the stent crossed the ostium? We actually, we actually crushed the stent, and then the stent is in the left main. So we are just trying to recross the crush circ to do a final piece. So you're saying that the stent could be the wire could be underneath the stent struts, is it? Or is it a possibility? I'm just trying to find another struts. So may make it easier, but.
Aaron, this is Fahim. In our lab, we had one case done by one of my colleagues. They used a blimp to cross the crushed stent because nothing else would go. That's something to consider.
Yeah. So we asking for it, but unfortunately, we don't have it in the lab here.
We have the claim, but it's used up. Is it? Can I just ask Aaron, what was your pot balloon sizing?
Yeah, I initially I used a 3.5, and after realized that we couldn't cross, so I used a 4.0 actually to pot it. Sometimes it works, sometimes it doesn't work.
Yeah, so a more aggressive pot sometimes helps. Maybe you can even consider a short 4.5 at the lower pressure actually.
Yeah, I see it crossed very easily these stent struts. Yeah.
Why don't you use?
Just that the balloon won't able to cross.
This is Florim from Switzerland. Why don't you use a wire like a Grand Slam? So very often, if I'm not able to cross in such a situation,
that's what I'm thinking. Maybe use a micro catheter to change it into a Grand Slam. It may cross. That's probably my last resort. So can I just change another wire? Give me a filter, please. Let's maybe we can go into another structure.
On the case I showed, I just for the fellows, I used actually 2 grand slams because I was not able to cross into the LED again, and then I used 2 grand slams and it went well.
So Jack, I think the time is 5 o'clock. So I will work on this final case. It probably take a while. Yeah. So I just show you the final picture that we did for the LED and diagonal. This is how it looks like. And then the spider view show the ostium of the cert is it looks good, but the thing is we need to kiss it to make it look better lah. Yeah.
Okay, so Aaron, thanks for working so hard over the last 2.5 hours for this very complex case. We have run out of time. I did see a lot of questions that we actually wanted to answer in the audience as well as Fahim's question. But I think in consideration of time, I would just like to summarize and close the session. There was a good questions from Professor Josselin. After you put in so many stents, Aaron, what is your depth strategy, even with biofreedom stents? Is it shorten, lengthen, or maybe you take that last question before you close?
As a normal stent, this patient don't have any high bleeding risk features, so I can use it as a normal workhorse DES.
So you would give 12 months at least or extended that with this?
Yeah, probably 12 months, yeah.
Okay, at least 12 months. Okay, great. So I think we'll come to 2 hours plus. I think we had a great session. We actually did prepare a lot of other talks comparing and reviewing the DK Crush series of stents and some videos showing DK Crush as well. But Aaron did a wonderful case in a patient who, after a heart team discussion, was rejected for surgery due to high stroke risk. And just questions from the attendee was that how do you minimize stroke risk during PCI as well? So just to emphasize that stroke is also possible during a PCI. And I want to take the point of Fahim saying that for this type of patients, it's probably not the first case fellows in the audience. It's truly extremely complex. And I will say that in this case, you see Aaron, my boss, working with Edu, so get experienced operators together and learn together for this complex bifurcation. In this case, Aaron did 2 bifurcations, 1 culotte in the diagonal LED, which turned out with a great result both on angiographic as well as...
Still struggling on the...
Still struggling, yes, we'll let you struggle more.
Struggling on the DK crush, the crush that
you had a DK crush in the osteo circ back into the left main.
Yeah,
I'll
so
say
the problem
that,
is, sorry to interrupt, the smaller the stent, the more difficult the crush. Yeah, this is one thing to learn. If the circ is huge, I think to cross this application shouldn't be any problem. So this is only 2.0 stent, so it may be difficult to cross because there are too many stent struts together.
Yeah, thanks, Aaron. So to harken back to Prof. Tan Hui Chin's first lecture, the point is maybe based on his lecture presentation, I might have simplified the DK crush in the left main by not doing a DK crush there and just provisional for this medium-sized circumflex, probably provisional for me to avoid having a 2 bifurcation strategy.
Yes.
So,
Jack, we cross. Jack, we cross.
Okay, you will definitely cross, but run out of time.
Because we changed the wire, change the stent strap. Yeah, go up. You can see that, right? Yeah. Okay, sorry. 8, 10, 12.
I'm not going to label this until you finish the case, but you'll cross, you'll do the final kissing. And we saw, and we didn't have time to emphasize, the teaching point to fellows is that depending on the technique, you should at least master 1 bifurcation technique. Now the evidence does favor that for most straightforward lesions without true bifurcation, provisional works extremely well. In a true complex bifurcation case, a 2-stent upfront strategy done well has better long-term outcome than the provisional strategy based on the presented evidence and the guidance presented. I also like Fahim's talk about narrating how to counsel a patient. regarding the pros and cons, and ultimately it's a shared decision making. I think more and more patients are veering towards PCI, and because of that, it's beholden to us to do as perfect an end result as possible. Two things for perfect end results. One is intravascular imaging. Intravascular imaging does help us get guidance needed for a better end result. The second lecture actually focused on achieving the better result. So Dr. Florim gave a wonderful lecture demonstrating a complex case with very good results. And he emphasized on the mechanical approach of gaining maximum lumen gain post-procedure. I think a variety of technique, plug modification, ultra-high pressure technique, adjuvant ballooning, all these are strategies that you should employ to achieve the maximum result. In this case, Aaron, I think you can still consider a larger balloon port at the left main. So I want to thank everyone for participating in this session. I think we will not get a chance to show this end result. I'm going to just let it run, but the session is closed. Before we close, I'm going to ask OB Van to stop share, and we're going to have a surprise for Dr. Florim. So I would like to thank the audience for staying with us to the end. I'm sorry we overran time this round, and I'd like to wish Dr. Florim happy birthday. What time is it back in Switzerland now?
It's 10 a.m.
You're looking fresher as we go on.
It's true.
So happy birthday, and thanks for joining us on your birthday to teach our fellows. And I'd like to thank everyone for their time. Since this session is live stream, we'd like to wish Dr. Florim happy birthday. I think all the faculty can leave. We will go back to the cath lab after this, and we'll, for those who are interested, Aaron can continue to take everyone through. I will also have to leave the session. Sam, are you okay to play or no?
We should sing a live happy birthday song.
Oh, really?
Shall we go? Yes. 1, 2, 3. Happy birthday to you. Happy birthday to you. Happy birthday to Dr. Florim. Happy birthday to you. See, all the men are too shy.
Yeah,
thanks a lot.
Very enthusiastic from Singapore. So thanks everyone. And we'll continue to go back to cath lab. Aaron, can you take it from here? And for the audience who want to leave, please leave. You want to watch Aaron struggle, please do carry on. So thanks a lot, guys.
Thank you.
Bye-bye.
Thanks.
Thank you.
So OB Van, we switch back to the cath lab and let Aaron take it. So Aaron, we're back to you. The fellows are still online looking at you.
Okay, so
enjoy yourself.
1-5 cross the third, 2-0 cross the third. We use a 225 NC balloon, but couldn't cross. So we use a new 225 NC balloon to cross the third. Yeah. Hopefully this will go through. Wow. Difficult. Yeah. So we may have to use a. Give me the 2-0 again, please. Maybe we dilate a bit bigger. So I think we just have to be very patient with this bifurcation lesion, especially the DK crush. The last kiss is always the most difficult. So you have to learn a lot of technique to how to cross this the last. The 2-0 cross quite easily actually. Let me see. Try again. Yeah, it crossed. Yeah, it crossed easily. Yeah. 2, 4, 6, 8, 10, 12, 20. Go.
20.
Okay, done. Okay, why don't we have the 3-0 in the LAD, and then we have the no. changed my mind. 275 in the LED. And then just anchor it if we can't. Give me the 225 first. Yeah, 225 first. 225. Yeah. 225. Okay. Oh. Got it? I got it. Wow.
Oh,
wow,
sorry
wow.
about that.
Yes, we cross. Yeah.
Yep.
Okay, wait. 2, 4, 6.
6,
8, 10, 12.
12,
14, 16.
16,
Down.
down,
2, 4, 6.
6,
8, 10, 12.
12.
Down. The wire. Okay, give me the 3 0, please. The other wire. Negative for me, huh? Thanks. Can they still hear me?
Yeah, I think you're still on.
Hold the wire, please. Okay. Negative, huh?
Negative. This is LED. This is the diagonal.
So make sure that it doesn't cross the diagonal. Okay. This one LED?
Yep.
Make sure it doesn't cross the diagonal. Oh. Okay, it's fine. Okay, yeah, 24 for the sub.
Fitting, sub 24.
Yeah, so high pressure, down.
Down.
Okay, 12, 14, 16, 18, the other one.
LED 16,
16, 18,
18,
20.
20.
Okay, down.
Down.
Okay, go up both. Huh?
Fitting, 2,
4, 6, 8.
4, 6, 8,
10. Go.
10.
Okay, down.
Down, 8, 7, 6, 4, 2, 0.
Okay, looks fine. I'm still watching on fast. Okay, so I think we decided we're going to rekey the thing, huh? Because the LED looks like it's not well dilated, right? Yeah. Okay. So 275 to the LED. Then let's wire the check out the circ wire.
Only the towards the distal part of the LED stand.
Oh, is it?
Yeah.
Okay. Then is that case? Then we don't need to. Yeah. Okay. Come. Give me the 275. 275 NC balloon. And then we finish.
Yeah.
Just the distal part.
Yeah. After the diagonal.
Okay. Okay. 2, 4, 6.
Bleeding 6.
8, 10, 12,
12.
14, 16.
16.
Down.
Down.
Which one? You can see the diagonal better. Epicranial, let me see. Okay, epicranial. More L. Okay. It's more test for me. Okay, plenty of space. 12.
Bleeding 12.
14.
14.
16.
16.
Distal meaning. Mean here.
Yeah.
Down.
Down.
Don't need the edge. But...
Okay. Yeah. Do a stem boost. See how good this stem. Stem boost. Okay. Ready? No. You take a deep breath. Center. Okay. Stem boost. Stem boost. Okay, fine. 12.
Bleeding 12.
14.
14.
Okay, down. I think we're enough.
Down.
Yeah, I think so.
Enough. Okay. Open up, please. Okay. GTM, please.
Nitro.
Yeah, go.
Nitro 100.
This view and then both cranial later. Go. No. Okay, come both cranial. A bit of bridge there. Sorry. Center. One last view, epicord. I think it's good to miss the ostium. Slide up for me, please. Okay, go. Yeah, the cert is fine. Okay, that's main cert got a bit occluded.
Yeah, but
small
it's
branch.
very small.
Okay, done.
Yeah, this already is because of the bridging, right? You don't want to touch it.
That part is bridging. This one lesion will leave it alone. Yeah, it's too far down. Maybe a bit of
It
bridging
may be
also.
bridging because it dives in.
Yeah. It dilates a little bit for down.
Yeah, got it.
Thank you. Look at me.
Sorry? Don't need that. No need. I'll let that, right? Okay.
Rider up, podcast 360, start therapy.
Jack, are you around?
No, I think he's out of.
Okay, so I think it's still live now. Those who are watching, I'll just show you the final picture. I think we just missed the ostium a little bit. From the caudal view, you can see, but I think from the OCT, the what we call it, the area is big enough. But other view looks fine. So a little bit of eccentric lesion there. Yeah, so I think there's a myocardial bridge in the mid-LED. Not going to treat that one. And then distal one, I realized that it's also a bridging as well. You can see during the diastole is dilated. So I think this patient is a bit complex. So the proximal part of the artery are all standard. So I think answer to Jet's question, I probably would extend the DAPT if there is no risk of bleeding. So I'd like to thank everyone helping in the lab and Jion for interpreting the OCT. So thank you all for staying to watch the live demonstration. I hope after the case, you guys have more, or this webinar have more